So thank you. It's great to be here. The first time I'm up in this space, and the view is just spectacular. So if you want to peek over there occasionally, it's okay. I won't mind. So as Andrew said, I'm a primary care doc, and a very proud primary care doctor, still see patients. I found myself many years ago, I won't say how many years ago, loving primary care but hating the system. And I actually remember very clearly the evening when it came clear. It was a February night here in Boston. Those of you who live around here know that it gets to dark about 4 p.m. or so. Had just finished a day of seeing maybe 35 patients in 7-minute increments, many of whom were double booked, work right through lunch. And then because of the stupid new electronic health record, I had to spend 2 hours after work finishing all my notes because I had to do all this pointing and clicking code monkey stuff. The day before, they'd announced that they're building a beautiful new ambulatory building at our hospital. But of course, the people going into that were ortho and derm and I think OBGYN, and we were still stuck in the crappy old building as primary care. And a colleague and I were sitting there sort of commiserating a bit, and she put it really clearly. She said, every day I lose a little piece of my soul. That we went into this because we wanted to help people. And they come to us and they've got such big needs, and I really want to help them. And I've got all this training to help them, but the current system doesn't let me do that. And I realized, wait a second, I'm a doctor. Last I checked, I took an oath not to serve this stupid system, but to serve our patients. And maybe if we want primary care to survive and thrive, we need to change the system. And I think we've been doing a lot of what I'd call putzing around the edges, trying to tweak the models. And the simple idea was maybe what we should do is start over. Now, that thought occurred to me about 12 or 13 years ago, and I've been spending the next 12 or 13 years playing that out. And what I thought I'd do is talk a little bit about the journey and maybe a handful of leadership lessons that have come to me and sort of along that point. Really, at the time, I said, we need to figure out a new model. What does it look like? And at the time, I happened to be spending part of my time running a interfaculty health policy program at Harvard. So in Harvard's dime, was able to sort of go around the country, talk to people, think about what I'd do if I was going to start from scratch. And I think, as Andrew said, the first thing that I realized is the reason why putzing around the edges doesn't work is there's a fundamental thing wrong with the way we deliver care. And that's that we have built the system in this country on the basis of transactions. It's turned into a transactional system. It's coding, billing, it's widgets off a line. And unfortunately, all the things we were trying to do to fix it, whether it's medical homes or meaningful use or incentive programs, were all more checkboxes and more transactions. And the insight is what we've done as primary care doctors for the last 2,000 years is about relationship. Right? And for many, many years, that's all we had, and we were really good at it. And then all these fancy toys came around, and we sort of got enamored with them and built the system on transactions. Right? Transactions have never cured anyone. Relationship does. And so what we need to do is get rid of the transactions and focus on the relationships and get them right. And it meant, by the way, not just doctor-patient, but there are a whole lot of other people who should be involved in taking care of patients. People we call health coaches and nurses and social workers and physical therapists, and we have to get those relationship rights. We've got the relationship between primary care and specialty right. And then we have to get the relationship between the payer of care and the provider of care right. If we get all those relationships right, now we can actually do something. And that requires starting over. So came up with the idea of how we'd build a system. We would change the payment model. Instead of billing fee for service, we get a fixed fee for primary care. And that will allow us to sort of think of our job not as seeing one patient at a time, but that we have a population of people, they're our problem. Our job is improve their health, keep them out of trouble. And just get all this coding stuff out of the way. It allows us to build a really robust team to serve the patient, let us spend the morning doing huddles and talking about our patients, being able to interact not just in visits, but by email and by text message, and get patients together as groups so they can teach each other, and go to the grocery store with them, and go see them in the hospital and take them on walks, and be proactive as well as reactive. We would integrate mental health into the model. We'd integrate dentistry into the model. It's silly, the teeth are part of the body, right? So really completely changed things. So all these great ideas, build a new IT platform, right? The EMRs we were using were built, not surprisingly, for the old system, document, code, and bill. They turned, and said, stop the madness, we should build what we thought of as a collaborative care platform that allowed us to collaborate with everyone on the team and the patient and their family. And you can start from scratch. So great ideas. And so I went to all the big health systems in town and said, I've got these great ideas. I want to build a new model of primary care. Will you let me? And they sort of pat me on the head and they said, that's really interesting, but our practices are full. We're making money. What's the problem you're trying to solve? The care sucks. Patients hate it. Doctors hate it. It's bankrupting the country. But from their point of view, unfortunately, and this was 10 or 12 years ago, they had no interest. And I think so lesson one really is, I finally decided, wait a second, if I really want to do something, I'm a doctor, I can start a practice. So let's just start a practice and do it myself. Right? There's a great quote by Ray Bradbury, sometimes you have to jump and build your wings on the way down. Right? And I think it's funny, I think so many people in medicine are so risk averse. They're so scared of trying to go out on a limb and doing something. And the simple insight is you will always get a job, right? That's one of the few things you can guarantee. There are plenty of jobs out there. So don't be afraid and just do it, right? So to actually quit the day job, took a second mortgage on the house and started a practice. Called it Renaissance Health for the rebirth of primary care. Opened a practice in Arlington, Massachusetts, a few miles from here. And we started learning a ton. We started getting patients to join. We had a simple, the insurers wouldn't pay us for most of the things we did because they weren't doctor sick visits. And we said, well, last I checked, we took an oath to serve our patients, not the insurers, so we'll do it anyway. And well, how are we going to get paid? Well, we just asked our patients, look, if everyone paid us, a little bit, $40 a month is what we put in the back of the envelope, we'll break even. If you can't afford it, pay us whatever you can. If you can pay more, and that'd be great. We can support other people. And we did this, and we learned a ton, and we learned about hiring health coaches and working in the community, and built up our practice for about 2 years. And then the powers that be around here started taking notice of us. And we got called into the office of one of the big health plans, and they said they didn't like our model. And I was like, why? And they said, well, people might think that you're working for the patient and not for us. which I think a lot of health plans perceive they're the product, we're a commodity that's just interchangeable. I said, no, for 2,000 years we have worked for patients. This insurance thing is a blip in history, right? But they kicked us out of the network anyway. And then we had been contracting through a big health system, and they said, this little experiment's been cute, but we've gotten complaints that you're raising expectations, you're making other practices look bad, and we're afraid this might upset the status quo, which you plead guilty to. It's exactly what we're trying to do, you idiots, is to actually do that. But you can't fight it. And so I think we were running out of money. We realized we had to sort of shut down this practice and try a different strategy. And I think lesson 2 in leadership is you have to be flexible. Things don't always work the way you think it will, and you can't get very enamored of your own plan, so you have to always be willing to change what you do and maybe change it a lot. And so the insight was really that what we were doing with better primary care wasn't just better experience for patients, which it was, and wasn't just better clinical outcomes, which it was, but that we were saving money downstream. We were keeping people out of the hospital, out of the emergency room. We went to all the health plans in town, tried to get the data to prove this, and they wouldn't give it to us. They said it was a HIPAA violation. They made all sorts of excuses. It's not, by the way. And so decided, who would be our ally, right? I think lesson 3 is, always find allies. And we thought it would be the payers, the self-insured employers, right? The people who sign the checks, they would be allies. So we did, and long story, teamed up with a gentleman, Arnie Milstein, who is a big healthcare thinker, and we wrote a paper about it, and he got us a gig with the Boeing company, right? So go to an employer, say, we will do this for your employees, build a different primary care model. And by the way, part of this is primary care is only 5% of healthcare spending, 5%. Right? It means 95% of what we pay for in this country is failure of primary care. Seemed like a really dumb investment philosophy, right? So we convinced Boeing, like, look, maybe we should change that. Let's double down on the primary care, double the amount of money going into it. We'll save way more than that, 5% on the back end. Trust us. And they did. So we built it, and we started working with Boeing and 3 big health systems, Virginia Mason, the Everett Clinic, Valley Medical Center, learned a ton, got data, because now we can get the data from the employer who told the health plan, give them the data, and showed we were lowering hospitalizations by 40% by doing primary care right, lowering ER visits in half. It shouldn't be surprising to any of you. I do a little game when I attend at Mass General. I walk around the wards, and I say, what percentage of these people could not be here if they actually had great primary care? The answer is a lot more than 5%, right? I tell you what, it's 40%. Walk around the ER someday. What percentage of these people sitting in the ER bays could not be here if they had really good, robust primary care, right? It's about 50% at least, right? So probably more. We did with Boeing. We did another project in Atlantic City, New Jersey with the Casino Workers Union, building a practice for them. And these were all working with big health systems. Again, we're still bootstrapping. We had no money. We're bootstrapping this, and it worked. And Atul Gawande wrote a great article about us called The Hot Spotters, if any of you haven't read it. And the phone was ringing off the hook with health systems. Can you help us sort of transform, re-engineer, whatever verb, your care? And I sort of said, you know, that's all nice, but there's a problem. And the problem was that these health systems we worked with, even the really good ones couldn't get out of their own way. So my favorite story is you know, culture mattered a ton to us, right? So it's relationship, I said, is key, and that's building the right culture. So we wanted to hire someone, we had to find someone with the right culture. And our best way of doing it is asking our patients, do you know anyone you think would fit the culture and would serve you well? And so we had an opening for a front desk staff in our practice in Atlantic City. And a patient said, yes, you should meet Betty, my neighbor. I was like, great. So Betty comes in, and Betty immediately meets what I call the hug test. You want to give her a hug the second you see her. She's got this twinkle in her eye, just incredible personality. You know, she spoke perfect Spanish, perfect English. Had never worked in healthcare, but worked in a lot of other hospitality jobs. And I can teach anyone how to operate the front desk, right? That's easy. I cannot teach the hug test. So I told Betty, that's great. You're hired, welcome to the team. And I called up the HR department at the health system, Atlanticare, and I said, you know the job opening I have? Yes, doctor. Well, I found my candidate, how do I hire her? They said, well, just send her over, we'll take care of it. So I said, great. So I sent her over, good luck, welcome to the team. I go back to seeing my next patient, and an hour later I get a phone call from HR. Doctor, we interviewed your patient, we rejected her. I was like, what part of hire her did you not understand? And they said, well, doctor, line 27 of standard Atlanticare job description says must have 2 years healthcare experience. So the guy, whose name is on the job description? Yours is. Great, delete it. We can't, you have to. Great, stay on the line, email it to me. They do, they email it, I delete the line, I send it back. I said, now, well, doctor, there's a problem. What's that? We have to re-interview the candidate. I was like, you know, I doubt anything's changed in the last 20 minutes since we've been on the phone. And they said, well, you don't understand. This is now a new job because you changed the description. We have to log the job, and we can't log an interview date that's before the job login date. So we have to re-interview her. So I was like, fine. I called poor Betty. I'm like, Betty, these jokers need to re-interview you. Why? I said, don't ask, just do it. Okay, so Betty comes in the next day. She interviews, I get a call from the HR doctor. We interviewed your candidate, she's now qualified. I was like, great, thank you. Like, so when's she gonna start? Well, there's another problem. I was like, what's that? Well, because it's a new job, we don't know what job grade to give it. So we can't hire her. I was like, well, how does that work? There's a job grade committee. They meet every 3 months. You just missed it. Isn't that funny? I was like, no, it's not funny. And so I pick up the phone and I call the president of Atlanticare, who we were working for. And I said, remember when I took this job and we were doing this practice and you said I could hire and fire who I wanted to? I meant tomorrow, not in 3 months. If Betty's not here on Monday, I quit and we're done. So Betty shows up. They figured it out. But I decided we're not doing this anymore. If, and this is the lesson, I think it's 4 now, is is really try as much as you can to get independence, right? There are a lot of rules in healthcare. Many of them are stupid rules. If they never let people break these stupid rules, we'll never know how stupid they are. And so, and I think part of the skill, maybe the only skill you need in trying to change the world is refusal to take no for an answer, right? Because the world will tell you no many times, and you just have to find a different way to ask the question, right? So always refuse to say no. And so so I decided I'm just going to do this myself. So we end up starting Iora Health about 5 years ago. Said instead of working with health systems, we're going to do it ourselves. We're going to raise some venture capital money, so we have our own capital. We can own and operate the practice. Everyone works for us. No HR committee, no rules. We can build our own IT platform because using the old ones didn't work. And we have since then now grown to 13 practices as of this week. We opened our practice number 13 in Denver, actually beginning of last week. Really sort of continue to evolve the model. Oh, thank you. Really are learning a ton about how to build robust primary care models and show to the world that this is of huge value. And what we've done, by the way, in our newest things is we flipped the whole pyramid around, right? So what we say is, as opposed to this pyramid where the hospital's on top, and then there are the specialists, and then maybe there's the primary care docs and the patients way at the bottom, we said we need to flip that whole thing. The patients are in charge. That we have these health coaches, people from the community who work with the patients, work for the patients. We, the docs, sort of work for the health coaches and the other staff, and we support all of that, and the specialists work for us. So we now get a group of, I call them partialists, not specialists. So we get a group of partialists who actually work for us. They're our suppliers, right? And we manage them like a supply chain. We have a compact with them, and this is what we expect for you to take care of our patients. You don't send people to other specialists without telling us. No, you answer our calls, you call us before making any major decisions, because our job is to be the patient's advocate, and we know what's happening through the patient. And if, by the way, you don't do those things, you're fired and you'll never see our patient again, and we will find someone else to do it. And we've now arranged the payment stream where the payment to specialists flow through us, so we get to just turn off the spigot, right? So, so completely changing the dynamic. The final lesson I want to talk about is something that Andrew's ended up with is people often ask me, what is it you do that makes a difference? We have unbelievable outcomes, right? So we can get 90% of people under control with hypertension. We can drop hospitalizations by 40%. We have amazing experience scores. What is it? And so the story that really stuck with me about a patient we saw, again, in Atlantic City, and her name was Joyce. And I was a doc who saw her when she came in. And she was just completely, the health coach called her a hot mess, right? Her hair was disheveled. She was sort of a little disorganized. She had a blood pressure of, I think, 185 over 90, diabetes out of control, not taking her meds, in and out of work, going to the ER regularly. And so we talked to her. We sort of got her with the program, gave her a health coach, enrolled her in some of the groups that we do. And then I had to leave the practice because we were actually thinking about starting our second one. And I came back 6 months later, and the doc, Neil Patel, who some of you may know, one of our docs, he said, Rishika, remember that lady we saw the first day, Joyce, who we said was such a hot mess? I was like, absolutely. He said, well, she's back. I want you to see her. I was like, great. So I walk in the room, and I don't recognize her, right? She looked amazing. Hair was combed, little makeup on. I look in the chart, blood pressure's under control, diabetes under control, back to work, no ER visits. So I look at her, I said, Joyce, you remember me? Yes, doctor. I said, you look fabulous. And she said, Doc, I've never felt better in my life. So I said, you've had doctors before. What have we done? Help me out. What have we done to help you? So she didn't say, you follow the medical home criteria, you meet meaningful use, she didn't say any of that. She said, what's really simple, Doc, she said, you all cared about me. You taught me to care about myself, and I didn't want to let any of us down. You cared about me, taught me to care about myself, and I didn't want to let any of us down. So it's almost that simple, right? If we want to fix healthcare, again, I'll leave with this, is we need to focus on the relationships. Relationship with patients, relationship with the system, relationship with specialists, relationships with the payers. If we get those right, all the other stuff will follow. That's how we change healthcare. And I think that's what leadership really is. So I'm very excited to meet all of you. I think it sounds like, I had this sort of training when I was doing this. I just sort of figured it out the hard way by getting beaten up a lot. But we need real change in primary care, right? Primary care is what will save US healthcare. It is the only thing that will save US healthcare. I think a lot of the attempts we have to change the system are what I'd call top-down change, hoping these big hospital systems will somehow muck around, hoping the government will fix the problem. The only way we're going to fix the problem is bottom-up, right? Build strong primary care, form great relationships with patients, use that as a lever to then rationalize the rest of the system. We need lots and lots of people doing it. So I wish you all the best, and if we can ever be of help, please let us know. Thank you. Thanks.
So questions, yeah, I know. Questions for Ruchika. We got about 5 minutes. We also want to give you guys a lot of time to continue networking. I think we've got some mic runners, Steph and Dave. Yeah.
So I know we're talking about changing everything from the ground up, and I think that discussion starts with changing the way in which we discuss the currency of change, as in, why are we doing this change? And I think your big point is that it's because of the patients, because of the people, because people are unhealthy and they shouldn't be. However, it seems like whenever we need to make that change, we have to make the argument for that change on other terms, mostly economical. And so that's personally where I find myself with primary care, whatever syndrome he had. Despondent syndrome, because I almost feel like I'm lying when I'm making this argument. It's hard to convince someone if you don't believe it yourself. So do I just put that in the box of white lies, or I wonder what you would say about that?
Yeah, so it's interesting. We're a for-profit company. We don't make a profit, but we aspire to be a for-profit company. But we are, and we have a number of investors who invest in us, who are venture capital firms. These are not do-gooders. These are people who expect to make a return. But there is no one on our board and no one in the company who thinks our job is save money in healthcare. Right? And I say that's not our job, right? Why? Because it's too easy to do, and it's too easy to go wrong if you think that's your job, right? You just don't do things to people, and we've seen that movie before. It didn't end up very well, right? So everyone who works with us thinks our job is do the right thing for patients, right? And have a deep faith that if we do the right thing for patients, we know for a fact that at least 30% of what we're doing in healthcare is waste. Right? And waste, by the way, be very clear, is not just things that are not useful, it's things that do harm to people. Unnecessary tests, procedures, being in the hospital you don't need to. These are dangerous, right? So our job is do the right thing for patients and have a deep faith that if we do that, the economics will work out. And you just need to find people who you can convince of that argument, right? Because, and say, this is what we're doing. We're doing the right thing for patients. By the way, it'll work out. Trust us. If you don't, we'll find someone who will, right? So I think that's, my partner always says, often you need to just show people where the high road is, right? They know it deep inside, but they need you to show it. Question up front.
Hi, my name's Victoria, and I'm from Georgetown in DC. I'm an undergrad right now. When you mentioned the first time you guys broke away and did the 2-year thing with the $40 a month, was that an example of DPC, direct primary care?
It was. So that was, we started out doing direct primary care, which I think is actually an interesting model. And direct primary care is simply where you say, ignore the insurance company, patients will pay directly for primary care. A couple problems with that in general. One is that you're asking patients to pay, insured patients to pay extra on top of what they've already paid for, because their insurance premium sort of already pays for primary care. So so what we've done now is we're now saying, and the second point is the problem in US healthcare isn't that there's too little money in the system, right? And we need more. That's a problem in Rwanda, right? The problem is US healthcare, there's an obscene amount of money in the system. We can take money out of the healthcare system and back in education and highways and other things. So asking people to pay extra seems silly. So what we're doing now is doing TPC, but with a twist, is where we actually partner with insurers to bundle the whole thing together. So we have practices, for instance, in Nevada, where you can pay on the exchange. You can buy a bundle of our primary care plus an insurance policy, but it doesn't double pay. And by the way, it's subsidy eligible, so you can get the government to pay for 75% of it if you're low income.
Sorry, I just recently wrote a paper on this. So I thought that in the states where they will allow DPC with specific definitions of medical homes and whatever, you'd have to make sure that there's a wraparound plan to take care of the catastrophic costs anyway. So is that what you're talking about?
Yeah, exactly. So if you want to be more technical, and people probably want, but if you want to be ACA compliant, right? So with health reform, there's now an individual mandate. So unless you want to get tax penalties, you have to have insurance. So you can't just get direct primary care. You need primary care plus wraparound insurance. So that's what we're doing. Yes.
Thanks so much, Rishika. Richard from Seattle. It sounds like when you started, you had to do a lot of advocacy kind of on behalf of your team to kind of convince people to give this a shot, to take a risk, try and convince Boeing to believe you that you were going to save them money, for instance. So now you've got a number, 13 sites you said, so you've got some not only some evidence, but patients who love the system, who I imagine would probably go to bat for the institution, for IORA, as partners in the advocacy efforts if you wanted to expand in Seattle or Denver. To what degree has the battle to start new practices gotten easier for you, and to what degree have patients kind of helped you in that advocacy to get people to kind of take a chance on you?
Right. So I think it's a great question. So one of my mentors and one of my heroes is a guy named Don Berwick, who I think many of you may know, who started and ran the Institute for Healthcare Improvement. He ran CMS till he was run out of DC by, no political comments. But but one thing that I asked Don a while ago is, if you had to do over, what would you do differently? And he said, I would not spend so much time talking to health systems, convincing them to change. I would spend more time engaging patients in helping us do that, right? And I think the way we're going to get the system to, the reason I am hopeful for system change is not that existing health systems are going to wake up and change. It's that I think the public and consumers are now starting to wake up, and there are a number of venues like with the exchanges and what people are expecting in other parts of the economy that will cause them to actually cause change to happen, right? So our mission is transform healthcare. The way we're doing it is simply building alternatives and letting patients vote with their feet, and that's going to kick the system into changing, right? So that means you have to really engage patients. You have to take seriously this sort of reverse pyramid where the patients are in charge, and you do it. So we do these patient advisory groups, dinners with patients every couple months. And what's neat is the patients don't talk about the practice or your practice. They talk about our practice. How do we make our practice better? How can we get more people to join our practice? We work for them, right? Not the other way around, which unfortunately most people think. When you do that, I think then you can engage them. So so we now have 2 new practices in Seattle, which are for Medicare Advantage for seniors. And our growth strategy is not marketing. It's a waste of time to put billboards up or send direct mail. What we do is community organizing. We get patients to have dinner parties in their house with others of their friends and talk about their experience, right? We go block to block and we hire organizers, right? So from the community. So I think as we think about how to change the system, getting the voice of the patient in the mix has to be part of it.
So let me ask a question that's related. I am not the only one in the room here who's guilty of being deeply ensconced in one of the large health systems locally. And so for those of us who are so ensconced, is it hopeless? Like, do we have a role? Can it be done from the inside? Or, as you were sort of alluding to in the answer to the last question, does it all have to come from outside the existing healthcare system?
So there's no reason it has to, there's no principled reason why we can't see this happening within health systems, right? I think, so again, if you look at how other industries have evolved quickly, is you have to give the way to change isn't to have everyone change a little at a time, is to find pockets you allow to change more radically. So, we have there are examples of creating sort of skunk work, so creating a place within the system where you actually allow a group of people to break the rules, right? So part of the problem why it's so hard to change within an existing system, why we have it easier, is we don't have rules, or we don't have a different set of rules that allow us to be much more flexible, right? And I think if, and one of the big health systems, you have a good idea, good luck going through all the committees and people approvals and all of that, whereas, we do it. So I think there are some examples. We're working with a couple of health systems now where they have decided they're going to create over here a sort of innovation group where we will, it's our group, et cetera, but we're going to let them break the rules. We're going to give them a different payment model. We're going to change the salary structure so it's not based on RVUs and all of that. And we're going to let them use a different IT platform so they don't have to stick with this sort of walled garden approach. And let's see what happens. That can happen. Again, I think the problem, I'm going to get in trouble here. I think the problem we face in healthcare is a failure of leadership, right? And I think, unfortunately, too many of the people running these big institutions have forgotten what our point is, right? The point of healthcare is to serve patients. It is not to propagate the institution. And there are lots of businesses in other parts of the economy, when people forget that, you need to be careful, so. Good.
All right, thank you so much for speaking. I'm Diana, I'm from across the river. It seems like you went through actually several iterations before you got to Iora Health as it is today. And as you mentioned, this change in the system, it's going to be a marathon. It's not going to be a sprint. Yes. But people get really tired during marathons. And not everyone has trained to be a marathon runner. So how do you help people through innovation or change fatigue? That I'm really tired, Rishika. How do you know it's going to work this time? How do you inspire those around you or kind of bring your team together when you've tried a bunch of things a bunch of times and it's worked kind of, but you're not quite there yet? How do you do that?
Yeah, so again, it all comes down to leadership, right? And I think, so one of the things really is sort of, three things. I think passion, vision, and hope. I think, having leaders who are just passionate about it. This is what we're doing. This is what we should be doing. I'm going to march on Washington. Are you with me or not, right? It's, I think, not asking for permission. Do you want to come? No, I'm going. Are you coming with me? I think it's finding victories, right? So if all you're doing is waiting for the final victory, that will come later much, but there are lots of intermediate victories. When you open the second practice, when you maybe break even, when you have. So we do. So we get our team together once a week, and we call it Terrific Tuesdays, and we actually explicitly share stories of how we made a difference in people's lives. And I think these little booster shots every now and then are really helpful. And then probably once a quarter we look at our data and let's look at our data. So build in sort of things that actually show that we're making progress on things, right? And then I think, as I said, just not refusing to give up. We're going to keep going, right? Because the alternative, giving up, is much worse. So, good. All right. Well, thank you all very much. Good luck.